Today, I will discuss the findings from a recently conducted study to assess the epidemiology, demographics, treatment characteristics, and healthcare resource utilization of desmoid tumor patients in Denmark. I would like to disclose that I'm a consultant and shareholder of SpringWorks Therapeutics. The study I will describe was funded by SpringWorks Therapeutics. Given that the estimated incidence of desmoid tumors is approximately 3 to 5 patients per million, nationwide studies are an optimal way to assess their epidemiology. Denmark serves as an ideal country to conduct such a nationwide survey, as the government gathers all patient interactions with healthcare providers and all medical diagnoses are registered. According to the Danish National Board of Health, all sarcoma treatments in Denmark must be confined to 2 nationally approved sarcoma centers in Aarhus and Copenhagen. The Danish Sarcoma Database was established on January 1st, 2009 to collect data on the treatment of sarcomas at these 2 centers. The Danish government prohibits the publication of statistics that represent 5 or fewer patients or allow for such statistics to be inferred, as their disclosure could be unblinding for patients. Throughout the presentation, such statistics are designated with 2 dashes, or ranges are provided when exact numbers could allow for their inference. We identified 192 patients registered in the Danish Sarcoma Database with a desmoid tumor between January 1st, 2009 and November 30th, 2019. We then excluded patients whose first contact was in 2019, given that we did not have full year data. We also excluded patients who had an error in their civil registration number, precluding linking the patients across databases. Finally, we excluded patients whose pathology codes were not consistent with the diagnosis of desmoid tumor, and patients who were under 18 at the time of first registration. A total of 179 patients remain with valid pathology codes, namely a code for aggressive or mesenteric fibromatosis, or for desmoid type fibromatosis. Each desmoid tumor patient was then matched on birth year, sex, and region of residence to 10 randomly selected subjects from the general population. I will refer to this group as the comparison cohort. The index date was the initial date of contact at the Central Sarcoma Center for the desmoid tumor patients and their matched comparators. We then assessed 4 key topics: the epidemiology, patient demographics, treatment characteristics, and healthcare resource utilization of the desmoid tumor patients versus the comparison cohort. The incidence of desmoid tumors registered at these 2 centers ranged from 2.2 in 2011 to 4.3 in 2017 per 1 million individuals. Previous incidence estimates range from 2.4 to 4.3 per million in Finland per Reitamo et al. In 1982, and 2.1 to 5.4 per million, excluding mesenteric desmoid tumors in the Netherlands, per Van Broekhoven et al. In 2015. The Dutch study demonstrated a statistically significant increase in the incidence of diagnosis between 1993 and 2013. While annual incidence varied in our study, there was no notable time trend between 2009 and 2018. As some patients experience a complete resolution of their desmoid tumors following surgical resection, we aim to estimate the prevalence of active disease rather than aggregating total incidence over time. Given that desmoid tumor patients are predominantly an otherwise young and healthy patient population, annual prevalence was estimated as the number of newly incident desmoid tumor patients, plus desmoid tumor patients from the Danish Sarcoma Database who had contact at a hospital in each calendar year, divided by the total population size of Denmark as of the end of that same calendar year. The early increases in the prevalence curve are attributable to a larger pool of aggregate registered patients from the Danish Sarcoma Database, and later decreases may indicate fewer surgeries performed, which I will discuss later. Estimated prevalence of patients with active desmoid tumors peaked at nearly 14 per million, or approximately 3 to 4 times incidence. We also assessed mortality among desmoid tumor patients versus the comparison cohort. We observed a small, elevated, non-statistically significant 5-year mortality hazard among the desmoid tumor patients. Importantly, most deaths occurred in familial adenomatous polyposis patients, despite only representing 7% of identified desmoid tumor patients. The low number of FAP patients precludes publication of mortality risk in this cohort specifically. The patient demographics observed in this Danish cohort are consistent with previously reported findings. The mean age was 38 years old, and 76% of patients were female. The Danish Sarcoma Database classified the sites of desmoid tumors as intra-abdominal or retroperitoneal, abdominal wall, or extra-abdominal wall. Small numbers of patients preclude the disclosure of most intra-abdominal statistics. Approximately 49% and 40% of patients presented with extra-abdominal and abdominal wall tumors, respectively. Compared to patients with extra-abdominal desmoid tumors, patients with abdominal wall desmoid tumors were younger, with a median age of 33 versus 44 years old, and more often female at 89% compared to 71% in the extra-abdominal cohort. Comorbidities were assessed using the Charleston Comorbidity Index. Nearly 90% of patients exhibited no comorbidities at the index date, similar to the comparison cohort. A history of cancer occurred more frequently in the desmoid tumor patients at 7% versus 2% in the comparison cohort. Nearly 1/3 of patients received a prior diagnosis consistent with a desmoid tumor before registration at the referral center, suggesting the diagnosis and potentially treatment of desmoid tumors is not exclusively confined to the 2 sarcoma centers included in this study. In evaluating treatment characteristics, we first assessed the use of surgery. Compared to patients with extra-abdominal tumors, patients with abdominal wall tumors were more likely to be treated with surgery, 78% compared to between 51 and 54%. Guidelines for the treatment of desmoid tumors have evolved over the last decade and have increasingly recommended an initial period of active surveillance and advised against initial surgical interventions in most patients. The first such regional guidelines were released in Europe in 2014, and similar global guidelines were published by the Desmoid Tumor Working Group in 2020. As such, we separately assessed the rate of initial surgical interventions at the National Sarcoma Centers among patients whose first contact occurred in earlier and later time periods, 2009 through 2014 and 2015 through 2018, respectively. The incidence rate of surgical interventions was 4 and 2.1 per 10 person years in the earlier and later periods, respectively, implying an incidence rate ratio of 0.51. 75% of patients with the first contact in the earlier period received an initial surgical intervention compared to 32% in the later period. This shift away from initial surgery was more pronounced in patients with abdominal wall tumors. We next assessed the use of systemic therapies. This included potentially disease-modifying drugs such as chemotherapeutic agents, tyrosine kinase inhibitors, non-steroidal anti-inflammatory drugs, and other hormonal therapies like tamoxifen, as well as other potentially related drugs, including opioids and steroids. Patients were defined as using these systemic therapies if at least one prescription for a specific drug was identified in the 3 years prior to or after the index date. Overall, the use of chemotherapeutic agents and TKIs was much higher in patients not initially treated with surgery. Sorafenib, the most frequently prescribed TKI, was used in 7% of patients. Opioid usage was high in surgically and non-surgically treated patients before and after the index date, underscoring the pain associated with desmoid tumors and potential morbidities due to surgery. Finally, we assessed the healthcare resource utilization of desmoid tumor patients versus the comparison cohort. The number of inpatient and outpatient visits per 100 people remained elevated for at least 3 years following the index date. In this period, desmoid tumor patients had on average 7.1 outpatient visits and 7.5 days in the hospital, compared with an average of 0.1 visits and 0.8 days in the hospital in the comparison cohort. The median length of desmoid tumor surgery-related hospital contact was 5 days. The average number of surgical procedures per individual, excluding initial desmoid tumor surgeries, was 1.6, 1.2, and 0.7 procedures among the initially surgically treated desmoid tumor, initially non-surgically treated desmoid tumor, and comparison cohorts, respectively. This suggests a potential high rate of post-surgical recurrence, which is documented in the literature, as well as a high rate of subsequent surgical interventions among patients who did not receive an initial surgery at a sarcoma referral center. In summary, the incidence per million of desmoid tumor patients diagnosed at these centers ranged from 2.2 in 2011 to 4.3 in 2017, and exhibited variation but no notable time trend. The prevalence of active disease peaked at 13.8 desmoid tumor patients per million in 2015. We observed a small, elevated, non-statistically significant mortality hazard, and most deaths occurred in FAP patients, despite only accounting for 7% of identified desmoid tumor patients. Sex and age distribution were comparable to previous studies, and approximately 1/3 of patients received a prior desmoid tumor diagnosis. The percentage of patients treated at these centers with an initial surgical intervention fell from 75% in 2009 through 2014 to 32% in 2015 through 2018, consistent with changes in treatment guidelines. Chemotherapeutic agents and TKIs were frequently used in patients not treated with an initial surgery. Opioid usage was high among all patients, regardless of active intervention. Initial intervention. Increased inpatient and outpatient visits and days in the hospital persisted for at least 3 years after contact versus the comparison cohort. On average, each initially surgically treated patient had 0.9 subsequent surgical procedures, and each initially non-surgically treated patient had 0.5 subsequent surgical procedures beyond the background rate of procedures in the comparison cohort. A manuscript that further characterizes the methods and results of the study has been submitted for publication and is currently under peer review. I would like to thank the desmoid tumor patients whose data contributed to this study. I would like to thank our collaborators in Denmark and at Epid Strategies. And I would finally like to thank the Danish government for allowing us access to this data.